Good afternoon and welcome to the Dibble Institute's November webinar, Relationship Education, a Trauma-Informed Approach for Youth. And we welcome Kristen, Plastino, and Jen Todd from University of Texas Health, and we'll be introducing them a little later. But just for the moment, I want to do a few housekeeping things. First, if you lose audio connection with your computer, the email we sent you to confirm this webinar has an alternative phone number for you to use to call in. And you know, all of us who have gone through the whole COVID thing must know by now how chat rooms, how questions work, how hands work, how polls work. So please just follow along because we'll be using all of those today. So actually, I'm going to start doing that now. If this is the first ever Dibble webinar that you've ever attended, can you please raise your hand? I want to see how many new folks we can welcome today. There's always new ones. We've been doing this for 4 years now, 5 years now, and it's always good to see who's new. So if you're new, would you please raise your hand? Great. A goodly number of you are new, and we want to welcome you to this. We do these webinars every month, second Wednesday webinars, and on topics of interest to people who are working with youth, especially in the space around intimate relationships. So for those of you who are new, let me talk a little bit about the Dibble Institute. I can't remember, did I say I'm Kay Reed, the Executive Director of the Dibble Institute? If I didn't, I should have. Anyway, here I am. And Rebecca, if I could have the next slide. Rebecca is our engineer. Thank you, Rebecca, for today. So this is Charlie and Helen Dibble. Charlie was our founder. And basically his vision was that you could take research and make them into practice tools, translate research into practice tools to make available to others, to help young people gain agency in their intimate relationships. That's really the Dibble Institute in a nutshell. We're a nonprofit publisher in this space of healthy relationships. That's where our feet are firmly planted. Next slide. But now, the Dibble Institute is a national independent nonprofit, again, providing teaching tools, curriculums, and other programs to clients all around the country. And in fact, just last week, we had a training where we had people from Samoa and Northern Ireland on the same call. And amazingly, you can manage that even with the time zone difference. And today, our speakers have been using Dibble materials since 2016. So we're really pleased to be able to welcome them. Now, two more things about Dibble I'd like you to know. The first is we believe in research. We're big science geeks. So Rebecca, the next slide. Yeah. And we believe in science. Our programs are all rooted in evidence, and we love to research them. And so we adjust our materials as new facts come forward, because science is never, you know, is always like a little bit of a windy road. So we just keep our materials current and up to date and based on the latest findings. And secondly, people sometimes ask me, you know, who is relationship education for? So Rebecca, the next slide. And the short answer is relationship education is for everyone, you know, for everyone, no matter who you're having a relationship with or who you love. We believe that everyone deserves to be treated with respect, and every relationship can be better with relationship skills. So that's how we write our materials with that in mind, and we indeed see them used in a wide variety of settings with diverse youth. So next slide. Today it gives me a great pleasure to introduce Dr. Kristen Plastino and Jen Todd. Dr. Plastino, and ladies, you can turn on your cameras now, is a board certified OBGYN specializing in adolescent gynecology and reproductive health. She's a professor at UT San Antonio. You can see she's wearing her scrubs today. She came right from the clinic. And where she's led a successful efforts to reduce teen pregnancy in San Antonio. Jen Todd is a grant project manager for many of the teen pregnancy prevention efforts that they have going at University of Texas Teen Health. She and her team recruit people in the field. They supervise their staff going out. They work on policy. She does amazing work. So with no further ado, want to say welcome to Jen and Kristen and let them have the floor. Thank you.
Thank you so much, Kay, and thank you to the Dibble Institute and the amazing team there for the invitation to present UT Teen Health's trauma-informed approaches with youth. Dr. Plastino and I will provide an overview of adverse childhood experiences, or ACEs, the effects of trauma, and discuss the shift from the existing paradigm of how to respond to youth to a trauma-informed approach. And then we'll share lessons learned from the field. Next slide, please. So UT Teen Health's mission is to advance adolescent health and wellness by providing medically accurate sexual health information to the community, encouraging positive youth development strategies, and promoting healthy life choices. Next slide. A little background on UT Teen Health. We are an organization that is located in San Antonio, Texas, and is part of UT Health San Antonio's OBGYN department. Our organization focuses on providing programs designed to educate and empower teens to think about their future and make healthy decisions. UT Teen Health also works with partners to link teens to clinical services as well as other services they may need. UT Teen Health and other organizations in San Antonio have been working collaboratively to reduce teen birth rates and repeat teen birth rates. In San Antonio, we've been utilizing effective programs in schools, juvenile justice departments, foster care organizations, community colleges, clinics, and faith-based organizations beginning in 2010 to present. And UT Teen Health has built the capacity of these organizations to implement and to integrate effective programs into their organizations. And so now we would like to know who exactly is here. So Rebecca, will you please go ahead and set the poll up? We want to know who's here today. Are you a teacher, social worker, nurse, community health worker, or other? And we will give you a moment to go ahead and check off who is here today. And then I will turn it over to Dr. Plastino, who will start us off with what is trauma.
Okay, well, it looks like we have a lot of others here today. And so I am just fine with that because trauma affects all of us, including others. First, let's just dive into what really trauma is. I mean, it can really take place at any time in your life. It can include anything from bullying to emotional abuse, neglect, physical abuse. What about school violence, sexual abuse? We know a lot about system-induced trauma and re-traumatization, and we're going to talk about that and how we try to prevent re-traumatization, transgenerational trauma, traumatic grief or separation. What if you witnessed something that happened in the community or community violence? You could witness domestic violence. There's all types of trauma that can be experienced, including from disasters, terrorism. I mean, COVID has been a new adverse community event that we have seen. Next slide, please. So let's really focus now on adverse childhood experiences. And when I say adverse childhood experiences, we're talking about those things that happen before we're 18 years old. Okay, and we're going to use this term ACEs. And it's going to be to describe all types of neglect, abuse, and traumatic events before 18. Next slide. So how many of you here have ever heard of ACEs? So Rebecca, go ahead and pop that up. I want to see what our crowd knows. You're going to have like 5 seconds to answer this. Have you ever heard of it? No, you haven't, or you're not sure. I'd love to know what our audience is. Okay, what do you got there, Rebecca? All right, so we have the majority of our crowd has heard of ACEs, which is great. And so when we're talking about adverse childhood experiences, I want to make sure that you are well versed in what they truly are. So go ahead, Rebecca, with talking about the original study. The original study on ACEs was conducted by Dr. Anda and Folletti. We're fortunate enough here in San Antonio to have been trained on the ACE interface with Dr. Anda, one of the original authors. And they really wanted to look at, back in the 90s, the relationship between these traumatic experiences in childhood and health and well-being later in life. And so this was a study that did kind of a cross-section of the population, but I want you to know that the majority of the population was white, middle-class Americans who had medical insurance. Now, in a case that I came straight from clinic, in the clinic that I work in, specifically on Mondays, I do not have a predominantly white middle-class American population with medical insurance. And so I cannot generalize what I'm going to tell you now to that population, but I can tell you when we just look at that population that was studied by Kaiser Permanente, they were the Kaiser Permanente patients, you can see here that the majority of them were, again, middle-aged, white, and they were pretty even between males and females. What did they find? Well, what they found in the next slide is that adverse childhood experiences are common. And they put them in 3 different categories: household dysfunction, neglect, and abuse. And this really shows that there are 3 types. And under household dysfunction, you can see parents separated or divorced. So yeah, that could be a lot of people that are affected by one adverse childhood experience. There are 10 total ACEs, but what I want you to remember is one is not worse than the other, nor did this quantify how much abuse occurred or how the perspective of the victim was, or the perspective of the individual having the adverse childhood experience. Let me give you an example. There might be a child who had sexual abuse during their childhood and is not showing any signs of the adverse childhood experience affecting them later. However, a child that had emotional neglect, some would say, well, that's less severe than sexual abuse, but that emotional neglect was, in the perception of the person having the emotional neglect, very significant. And so what I'm trying to get across to you is these are common, and you can see the percentages, but it doesn't mean they're all perceived the same by individuals, okay? And so please know they are common, common, common. Next question. In the poll, we have, which of the following can be caused by ACEs? So, and I just told you there are 3 different types: household dysfunction, neglect, and abuse. I told you they are common. There are 10 of them. Are any of the following caused by adverse childhood experiences? Is asthma caused by an ACE, diabetes, workplace injury, smoking, or none of these caused by ACEs? Show me what you got, Rebecca. Okay, so about half of you think that diabetes is caused by it, about a quarter for workplace injuries, and about a quarter of you believe that none of the above are caused by ACEs. So let's go to the next slide, and I want you to look at this. I like to think of it as more of a oil splotch. Like there you have a big white piece of paper, and you throw oil on it, and we let it leak out. And let's see, this kind of gives us a visual of how much of each one of these population risks is attributable to ACEs. So we understand ACEs are common. We know that they can have an impact on risk of certain health and social problems. Heck, I wouldn't be presenting it to you if it didn't, right? And we know that if we can prevent ACEs, we could prevent intergenerational transmission of ACEs. And I want you to look at this slide to understand the percentage of these various health and social problems that epidemiologists are estimating are caused by ACEs. And so Yeah, we can bet that probably if you have ACEs, 41% will have chronic depression is caused by ACEs. Okay, I can believe that. Alcoholism, 65% of alcoholism is caused by ACEs. That makes sense, right? Smoking, guess what? What do you do when you smoke? Deep breathe, right? Isn't that a great tactic for relaxation? Well, guess what? You're self-medicating with smoking because of your ACEs. Workplace injury, drinking and driving, cancer. A quarter of cancer can be attributed to ACEs. And so again, this population attributable risk is showing you that the percentages are quite large. In fact, I don't know of any other public health studies that show such a risk of something happening in the community or happening to you as being a causal factor for something later in life. Next slide, please. So ACEs can have lasting effects. So we're talking about things that happen in our less than 18-year-olds can have lasting effects on our health. And people can have poor health through the rest of their life. And this slide really looks at the number of ACEs on the x-axis compared to the risk of negative health impacts or outcomes on the y-axis. And you can see that greater than five or more ACEs, the more likely you are to have negative health effects. And so that would be specifically with regard to smoking, alcoholism, drug use, graduation rates, right? I mean, think about it, things that have happened to a child that might be in the system, in the foster care system, and they get adopted at the age of 2 into a loving home. They get everything that they need for growth. Things that happen to them less than 2 can put them at risk for things later. And so we have to remember that. Why did we even get into this? When Kay gave us a introduction, we really were talking about teen pregnancy prevention, right? Like, how the heck did Kristen and Jen get into ACEs with teen pregnancy prevention? Because what we realized was teen pregnancy was just the tip of the iceberg and was just a symptom of a much greater problem. And so as we started going down into the base of that iceberg, we realized that ACEs had a huge impact on our relationship training, on how we truly are trauma informed in what we do. Next slide. So people with 6 or more ACEs in this study died nearly 20 years earlier on average than those without ACEs. So the life expectancy of 60 versus 80, right? So we already know how long people may live if they have those ACEs. And I pause as I say ACEs because I think to myself, but it's also in the perception of that individual. It's also how they translate it. It's also how it affects them, which might be different than how it affects the same sibling in the same household. So with that, I think we pretty much got across to you about ACEs, what they are, if you didn't know what they are, if you did know what they are, how common they are, and how they can really affect our life later when we are adults. Jen, why don't you go ahead and take it from here and talk about the effects of trauma.
Thank you. So next slide. While we understand some of the effects of childhood trauma are outlined, we also, what we'll go ahead and do is now explore various reactions to trauma and share with you some experiences of what we've seen. These reactions can occur immediately following a traumatic event, or the reaction may actually be delayed and come out later, sometime in the future. Next slide. So reactions to any traumatic event may be emotional, physical, behavioral, cognitive, or existential. And these reactions to trauma can be or will be explained shortly, and examples shared of how we've seen them presented in various settings. Next slide. Reactions to any traumatic event can vary from subtle symptoms to destructive behavior and can shape the way an individual views their future. Those often affected by traumatic event may experience loss of hope and alter their expectations about life. They also may fear their life may end prematurely or that we will not experience the normal life events that others have experienced. I was talking to Dr. Plastino just before this webinar, and just looking at some of the teens that are coming through the clinic right now, they really, because of COVID, have truly feel this loss of hope. There's a lot more just anxiety. And so I think our mental health providers are really going to be stressed as far as not having availability because of where we are. We're used to connection, and that's been, you know, just minimized or in some cases taken away. Next slide, please. So the immediate emotional reactions to an individual may experience can include feelings of anger, anxiety, sadness, disorientation, denial, and guilt. And delayed emotional reactions can include depression, grief reactions, shame, feeling vulnerable, and emotional detachment from anything that requires that emotional connection. In the school setting, we've sometimes seen where students will come into class with a hoodie, you know, over their head, really kind of hunched over, not trying to really be ignored or just not noticed. And you know, that may be a sign, that emotional sign of a traumatic event that they've experienced. Sometimes it might be something as simple or something that happened earlier that day or something that they just started thinking about. We've also seen this take place when we've been in juvenile justice and have seen all of a sudden somebody looks at, a student looks at another student differently, and that sets something off. And so they start throwing desks, punching walls. And so it really is, I want us to remember every behavior is because of an unmet need. And so when we're looking at trauma, this is one of the emotional effects of trauma. Next slide, please. Immediate physical reactions may include symptoms of overly excited nervous systems resulting in nauseousness, sweating, muscle tremors, elevated heart rate, highly sensitive startle responses. Delayed physical reactions could include changes in appetite, persistent fatigue, increased attention and worry about body aches, changes in sleep patterns or sleep disturbances, and long-lasting health problems such as heart, liver, or autoimmune diseases. And I think when we think about just how COVID specifically has affected all of us, I think each of us, as I'm reading through it, I'm sure you're saying, yep, had that. Yes, sleep disturbances, absolutely. And just to share with you a story of my own daughter who had experienced a traumatic event. She all of a sudden would just, as soon as we would pass by this this place that she was going to receive dance lessons, she would, anytime we would pass by there, she would complain of a stomach ache and a headache. And we just didn't put two and two together until we started asking her, you know, what's going on? You know, why is it every time we pass by here, your stomach's starting to hurt, you have a headache? And it was because she just really did not like the fact that she was being pressured to dance long hours and was really just feeling anxiety about that. And so we ended up stopping that. And anytime we do drive by there, sometimes she will say, like, this is making me a little anxious. She has sweaty palms sometimes, but you know, we took her away from that. And I think sometimes even as parents, we forget that, you know, something that we think so small is actually a big event for our students. Next slide, please. So looking at intermediate behavioral reactions can include disturbances in sleep and appetite patterns, increased drug, alcohol, and tobacco use, withdrawing from their environment or having avoidant behaviors, expressing themselves, or maybe being argumentative. Behavioral reactions that may occur at a later time include disruptions in social relationships, decreased activity level, and then engagement in risky behaviors. So I remember a student that was attending one of our Love Note classes actually, and had been participating in activity, and an activity was kind of the center of attention. And this was probably around week 4. All of a sudden just was really being disruptive, very much not wanting to pay attention, being very, anything I would say, he would go against it, and just very just disengaged. And so I remember pulling this young person aside and just asking him, you know, what's going on? And it turns out that his parents had gone through a divorce, and he was having to go from one house to another. And he was just not getting enough sleep and just dealing with a lot of just those issues. So, you know, definitely be curious and not furious when you're talking to your young people, and just trying to figure out the why, you know, what exactly do they need from us. So reactions to a trauma can also affect an individual's cognitive function. Next slide, please. This can include the following immediate reactions: difficulty concentrating, replaying the event over and over again in one's head, distortion of time, making the event seem as it happened in slow motion, and sometimes poor memory recall. Cognitive reactions that are delayed may happen in the future to include flashbacks, or reactive on the traumatic event itself. So difficulty making decisions, beliefs that certain behaviors will protect them against future traumas, and suicidal thinking. In the clinic, we often saw young girls coming in, and you know, they had been at a certain weight and were just kind of struggling with, they would say, like, I'm really struggling with my weight right now. And when you started asking questions, it was because they had been through some type of sexual abuse, and they really were trying to make their body not just one that was not desirable to somebody else that might look at them, one that was really just trying to try to make them, they were wearing baggy clothes, really just trying to soothe themselves and heal themselves this way. Next slide, please. So we also understand that some individuals may experience existential reactions, and these types of reactions are concerned with a particular state of being as opposed to the truth about or knowledge of something. Immediate existential reactions can include turning to a higher power and engaging in intense use of prayer or restoring faith in the goodness of others. On the other hand, some people may feel despair about humanity, the loss of self-efficacy, or disruption of assumptions about life. Delayed existential reactions include evolving into a question of, why me? Why is this happening to me? So there's an increase of hopelessness and loss of purpose. And then we also understand that others may experience a renewed faith and reestablish priorities or rework assumptions to accommodate that trauma. And I think it's important to note that, you know, the effects of trauma can be immediate. They can also be delayed. And there's often things that may trigger. And so on the next slide, there are some triggers that we just wanted to just make you aware of. An additional consideration for individuals who've been affected by trauma is the likelihood for experiencing triggers. And it's that stimulus that sets off a memory of a trauma or a specific portion of a traumatic experience. And some triggers can be obvious, such as a location, as with my daughter, while others are subtle and can be a certain odor, like a cologne. Once had someone mention that a pear was a trigger for them, and it can catch the individual off guard. And so when a trigger occurs, it's important for that individual to focus on the present, to take deep cleansing breaths that may help. Using things like Mind Matters is also a way to just kind of help bring that mindfulness to you and helping that person to be regrounded. Sometimes it's a matter of maybe holding onto a wall or pushing up against a wall, which helps them distinguish that what's occurring in the present and what has occurred in the past. And so with reactions and triggers that we've described and illustrated, it's important to understand that an individual's reaction to trauma can vary. Many of the reactions can be viewed as acting out, mischievous, disobedient, disrespectful, or even dangerous, especially when we're working with our youth. Historically, such reactions, an individual would ask, well, what's wrong with you? I can't believe you. However, there's been this national paradigm shift that has changed the conversation to now ask, what's happened to you? And utilizing this paradigm shift has found to be more effective and beneficial when responding to youth. And so I'm going to turn it over to Dr. Plastino, and we're going to share some lessons learned from the field of working with our higher risk youth, specifically those in foster care and juvenile justice, and some of the lessons we've learned and some of the approaches that we've used that has offered the question, what has happened to you, and helping us to be curious and not furious with their behavior. Next slide, please.
Thanks, Jen. So as we move on, give me a thumbs up. Can you hear me, Jen?
Yes.
Okay. And so as we look at asking what happened to you, we've really changed our approach to our youth that we work with. We always thought we were trauma informed, kind, get the connection. But what we realized was we were far from it. And so what we hope to be able to do for you in the next few minutes is really kind of share with you some of the things we learned and how you can start to consider using some of those in your workplace environment or even in your own home or workplace. And so one thing we learned was that we need to incorporate this throughout all our lessons. And it can't just be, I remember us first writing our first curriculum, at the end it said, use trauma-informed approaches. Well, what does that mean? I mean, really? Well, one of them is, why don't you try using deep breathing to start a lesson or refocus between activities? Any of you that work with juvenile justice, you might find, oh, can you switch slides for me, please? Sorry, Rebecca. If you take that deep breath and start your lesson, because when we've worked in juvenile justice, there might be a fight that breaks out. And when the fight breaks out, even amongst the participants or somewhere else that they know is going on, everybody's looking, right? Everybody's looking. And then how do you get them to come back to you, right? And we found that using our deep breathing techniques and also providing an agenda on what they can expect that day with you is really important. We didn't go into all the stuff about ACEs and the hyperness of the nervous system in detail. I know Jen mentioned it, but the hyperactive nervous system, and so very startled and not knowing what's coming next. But if you give an agenda like, okay, for the next 10 minutes, we're going to do this, then we're going to do this, then we're going to do this, and you stick to that agenda, be very predictable. And then at the end of that lesson today, tell them what to expect the next time. Now, it doesn't mean you can't change things before the next time, but the next time when you meet, letting them know, hey, I know I told you we were going to do this, but I've been thinking a little more about it and I think X, Y, and Z, so we're gonna do this. So it doesn't mean you have to stick to it, but the agenda, that was feedback from the youth to us. And this is our systems involved youth, which means foster care, juvenile justice. We had our trafficked youth. We had all types of youth that are, I guess you could call them higher risk, even though all our youth are high risk. And so these are a couple things, and you can also see in the bubble things that that our youth wrote, positive messages to themselves. Next slide. Okay, so also we got to remember to meet youth where they are emotionally. Okay, if they just got out of a fight, if they just had a parent arrested this morning before they came to school, maybe emotionally they're not right there with you trying to tramp along this this lesson. And we need to acknowledge where they are, what they're feeling, and justify that. Try not to name their feelings for them, okay? You want to describe what you see, but not name the feeling. Instead of saying, you look mad, you could consider saying something like, I see your fists are clenched and your your jaw looks really tight. What's going on? Then they can name the feeling. They can tell you, because maybe they're not mad. Maybe that's the way they look when they're sad. You don't know that. And so name what you're seeing, not what they're feeling. For example, when discussing a goal with a student, a student might tell you, hey, coach told me I would never amount to anything. And you could say, thanks for sharing that with me. Can you share with me what is a goal that you want to accomplish, right? Well, I want to finish school. And then you can continue with guidance and acknowledgement, right? But coaching them through it. I think one of the other things is making sure that the group agreements that you all acknowledge in the beginning of your class, these are real important, right? Group agreements. What are we all as a class or a group agreeing to? Maybe we're not going to share personal stories. Maybe we are going to share personal stories, but they have to be short. You know, whatever your lessons are or your rules are, you can get up and go to the bathroom, or no, you can't get up and go to the bathroom. So make sure you have very clear expectations and let the students or the youth set the goals. Give them control, because when there is a sense of lack of control, it is hard to move forward. And we all know, as Jen said over and over again in her presentation, connection. We need connection and we need to feel safe in order for anybody to learn anything. And so make sure you're making that connection in a trauma-informed way. Next slide. Okay, so next we see that we want to really be prepared for real-time challenges. Any of you that are parents, grandparents, heck, any of you that even exist in this world today, real-time challenges have been something we've dealt with every day, right? Like, it just doesn't always go our way, right? What if you walk in to do a presentation and there isn't any wall space to hang things on? Oh my gosh, what do you do, right? You got to be able to adjust to it, right? You need to be able to debrief, because you know what? The emotional challenges these youth are facing every day, you're going to wear it too. You might not wear it the same way, but what we found is we had a significant amount of emotional burden in our implementers. And so for you bosses out there that are like, what could they possibly be doing? They need to be doing 8 lessons a day, going into 8 classes a day, seeing 20 youth per class, bam, bam, you know, let's go. We got to hit our numbers for our grants. I want you to remember that people need to take a break, especially if they're in these heavier situations. What I mean by that is a youth comes in and tells them something that happened at home last night. They might be triggered by that, the implementer, or feel bad for that youth, and they need to debrief. We found our facilitators could not facilitate day in and day out, and I feel my team is very strong with regard to being able to implement evidence-based programs, effective programs, one-time programs, 16-time programs, any type of program. They are experts at implementing. but they needed an emotional break. They needed time to come into their office and just debrief with other people there, perhaps journal. They had to do some self-care or mental health care for themselves, because it was pretty heavy to be implementing with youth with so many adverse childhood events, so much, I don't want to use the word baggage, because guess what? That was actually trauma inducing, that word. We used to talk about getting rid of your baggage. Guess what? When you're a foster care youth, that might be all you have with your entire life, is that bag, your baggage. And when we tell you to get rid of the baggage, we're basically throwing you out into the trash can too. And so we learned, don't use that word baggage. It's pretty hurtful to our systems involved youth.
So the language that we did use instead of baggage was past experiences, because past experiences can be both positive and negative. And that just helped them kind of acknowledge their past and move towards the future.
Excellent. One other thing is co-care. When you have an implementer, a facilitator that is really getting down and really needs self-care, if you're that deep into your downness, you may not even realize, and you need people around you for co-care that can pull you up and get you to the part where you can start taking care of yourself, recognizing each other. And so this isn't, what we're talking about here is not just about how to work with the youth, but how to work with each other, how to be resilient in this difficult field we can be in, where the kids really need us. Next slide. Okay. We learned a lot in juvenile justice, like cardstock paper can be used as a weapon. Do not use cardstock. Numbering everything you brought in, right, Jen? Pencils, erasers, because pencils can be a weapon as well. And you have to number them going in and number them going out. Jen?
We also found that there's such thing as a stapleless stapler. It sounds like an oxymoron, but that is what we need to use when going into some of these residential treatment centers, detention centers, juvenile justice. It's important that you know exactly what you take in and what you're taking out. We also found that if we wore a blue or red, we were affiliating ourselves with a gang color. And so we really tried to wear neutral colors. Obviously, Dr. Plastino and I, because we're wearing blue today, would not do well in the situation. And what that translates to is students will actually, if you're not wearing their gang color, they won't pay attention to you, and sometimes they'll be disruptive. And so we really try to avoid wearing colors and even having stress balls within those colors as well. So really trying to encourage just neutral colors. We also just made sure that anything we took in, we brought out as well. We couldn't have paper, so we could distribute paper, and we had to pick those up. So just really making sure that you talk to these organizations beforehand to let them know what their policies are, and how you can ensure that you're meeting the fidelity of your program, but also being cognizant of the needs there. And I think it's important too to just look at, we have pictures here, and these are things that our students have written. So I got you through whatever. I care about you a lot. I love you with everything I get. I trust you. I believe in you. I want to see you have a bright future. I will help you with anything you have trouble with. And these are positive messages that our students wanted to hear from the people in their lives. We try to say trusted adult, and oftentimes that was us, the facilitator, because they truly didn't have someone that they could name. as a trusted adult. So really just trying to build those connections as much as we can.
I think that was a real eye-opening experience for us, was as we started to really try to focus on building developmental assets and making sure they had a trusted adult in their lives. Over and over again, we heard in many separate sessions, what are you talking about? Like, I've never had an adult that didn't let me down. And imagine being that facilitator. Sometimes it was very, very surprising when they would hear that. So as we wrap up and look for time to look at our chat or questions, I want to leave you with a few things, and Jen will definitely comment with me. Number one, remember that every behavior is truly a way to communicate with you. And so instead of being furious, be curious. Why are they having that behavior? What are they trying to tell me? What has happened to them before they got in here? Works really great for patient relations too, in my world, right? Like, what's happened before they get in this office? So behavior is really communication. Be curious, not furious. And remember to take care of yourselves. I think that's one thing we forget about. And as we've really did capacity, not capacity management, that's what we do in the hospital with not enough beds. But when we do capacity building, with our teen health program, I think we found so much turnover in our foster care agencies, not as much juvenile justice, but in our foster care agencies. As fast as we would train people to do an effective program, they would be gone. And it was like, what the heck, what's happening? And what we realized as we started implementing was, it is hard work. This is hard work. It's emotionally taxing. And so hats off to you all in the field, trying to do trauma-informed care. I hope you're able to take some things that we've said today with regard to baggage, with regard to pictures. Pictures of female genitals can be very traumatizing for individuals. And you might just plan on whatever you're doing could possibly trigger someone, no matter what. It could be the perfume you're wearing. That could have been something that had happened. Their mom wore that perfume and she had domestic violence in the household, and that triggers them. You don't know. So having that curious mind is so important. Jen, I'm going to let you wrap it up.
Great. So I also just have a motto that we often use on our team, and that's bring your calm before the chaos. So, we never know what we're getting into as facilitators, and we never know just the environments and, how we're going to engage and interact. So just, be that calm within the chaos. And so with that, we are going to launch our last poll. And we just want to know, do you think trauma-informed approaches can be applied in your daily routine? Okay. And so I love this, 100%. So all 344 of you said yes. So I am excited to see that and hear that. If you would like more information on trauma-informed approaches, there is, next slide please. You can visit our website at utteenhealth.org and utilize the password to take you through a deeper dive into trauma-informed approaches part 2 through 4. And one of the things that we want to leave you with today too is that we understand that adverse childhood experiences and trauma-informed approaches are just kind of the, I like to say, just what we see in the iceberg, right? We don't see the underlying, the bottom of the iceberg. And so we are working at UT Teen Health to provide our community some resiliency training as well, and to bring hope And so that's what the next steps are, is really just trying to work within our communities, within our programs and our organizations to bring hope and to really build strong communities that do ask questions of how can I help, what happened, and what I can do to help serve you. So we want to thank you for your time, and we will, not sure if we have time for some questions. My phone number and email is there, so please, if you have any questions, please feel free to reach out to us.
Great, I have, this is Kay, I have some questions for both of you. So Dr. Plastino, as you were wrapping up, you had some great information there, but there was no slide accompanying it. So Amy asked if there was a way we could get from your mouth to a piece of paper what you said there. Remember
which part?
You know what we'll do? We'll have somebody transcribe it from the webinar. I think that's what we'll do. We'll put you off the hook.
You couldn't hear me?
No, they could hear you. They just wanted to take it with them. So
okay.
So don't worry about that.
Be curious, not furious was one of them.
That part. Be curious, not furious. Every behavior is a communication.
Right.
And so really consider that. And then I was also talking about the trusted adults and how our youth don't have any.
Right.
And how, but be curious, not furious, and really look at every behavior. And I will tell you, I have 4 teenagers, and right, I work with teens all day, I work with teens all night. And so the curious, not furious has brought me a lot of peace in my house. And just shut my mouth and listen. I think we always try to fill the space. In fact, when we were getting ready for this, I said, oh, what do we do during the polls? I hate silence, right? Because I'm really trying to learn that. And I think as adults, we just can't try to solve all the kids' problems. We just need to be quiet and listen, just listen. Oh, the other thing I said was, I don't know if it was this part of the presentation, but describe what you see, not don't judge what you're thinking they are doing. So I think, you don't say, you look mad, you look sad. Boy, does that really tick kids off sometimes, right? It's like, I see your fists are clenched. I see your eyes are squinted. What's up with that?
That's a good idea. Okay, here's a fashion question. Is black a neutral color? So in gang, it's very thoughtful and important to consider gang affiliation. So what would be, maybe let me word it a different way. What would be some colors that would be okay to wear into corrections that would, be, anyway, what have you found?
Great question. So I will tell you what our staff typically wear, which are black, white, khaki.
Gray.
We also have gray. We have on our team just gray polos. And so all of our team just looked uniform just because we wanted everybody to know this is who we were coming in. And also if we had any issues, they'd know exactly that's UT Teen Health staff.
So we had a logo. We have a logo on our polos.
Right.
But yes.
Okay, so here's a deeper dive. How have you helped and supported youth and youth development professionals, process the unrest for racial justice and the implications of fighting for racial justice after what is considered the civil rights era?
That's a deep one. Yes, you are correct, Kay.
Yes.
I would say for us, it's really been ensuring people have space to be able to talk, space to be able not just talk, but discuss. I also think kids are watching us as adults as to how we respond to things we either agree with or disagree with. And so I guess really trying to have that conversation and show respect for the other people in the room, redirecting those youth to be able to show respect for whatever the view is, whether you agree with it or not, and trying to be very neutral in our opinions, well, actually not even showing our opinions. And we do that training, Jen, if you want to talk about how we try to make sure that we are not bringing our own beliefs in.
Yeah, so we really have tried to focus on being values neutral and allowing space for our youth of color and even our facilitators of color to just, let them speak and be heard, and really just encourage just that time. Sometimes it is silent so that we can just listen and really just be able to see how we can process, and maybe it's something that we can do immediately to help reflect a change and provide some sustainable change, but really just listening, trying to be values neutral, and then providing space so that voices are amplified and heard.
Great, thank you. Before we wrap it up, just one quick question, Jen. In your slide that you showed the 3 hot links with the various, 2, 3, and 4 to the various things. Is there lesson 1? Or
Yes, there is.
Okay.
So there is, and it's very similar to this. Same password. And so if you go to the website, you'll be able to access them all.
Okay, great.
And just so you know, those modules, all the public school districts in San Antonio, or almost all, have mandated every employee to watch them. So 1 through 4 is available. We just didn't want to be redundant and list route 1, because you got a lot of what 1 is about today.
Great, well, thank you. We're still getting more questions, and for those of you who are putting them in, we will answer them in an FAQ that's attached to this webinar that we're going to post online next week. And the slides will be available next week. So the next slide, please. So thank you for joining us today. I would say just, you might want to check out Mind Matters Now on the Dibble website, which is online on-demand learning for caring adults and facilitators to, you can earn continuing education credits and also do self-care. So it's under programs, Mind Matters Now. Take a look at that. It's just brand new, and it's, Jen mentioned Mind Matters Now, and it's a way for adults to get that content. Anyway, we will be sending out the webinar next week, and here's our email addresses. Next one. So stay in touch in all the normal ways. And we will be subscribing you to our newsletter if you're part of this a part of this webinar, because we put in lots about funding and research and other things that lots of people want to know. Last slide, please. So next month, we go dark with live webinars, but what's super fun is that we encourage you to look up the webinar of your choice. And this last year in 2020, we've had a webinar on online teaching strategies, scaling programs in rural areas. The author of the book Social Poverty spoke, relationship education in Hispanic youth in Los Angeles. We had all kinds of great programs, and of course this will be on there as well. So we encourage you and your staff to use this resource. We will be back with live webinars in January. So thank you very much, and I think we're gonna, so I appreciate all the questions that have just come in. I see them, and we will put them in an FAQ so we can end this on time. So Jen, Dr. Plastino, thank you for your generosity. You knocked it out of the ballpark. Really appreciate it. And to all of you, have a safe and sane holiday season. And yeah, stay in it for the long haul. Thanks, and take good care. Goodbye.